Sometimes the best thing that I can provide is a smooth transition from this world into whatever comes next. Geriatrics is a lens shift for people. A lot of times our goal is really to do with people what is most important to them and to find out and align our goals with them.
Exercise, keep your blood pressure under control, try to keep a healthy weight. If your brain is not getting blood through it, which is what happens at a stroke, high blood pressure is the main thing, but treat your heart and your brain the same.
But we can also intervene in your lifestyle. We have evidence that makes a difference. It's not just therapy is important, but it's more than that.
So cognitive concerns come to us usually when prompted by a family member. Somebody that is truly demented will minimize that they have anything wrong with them because they lack the insight and they lack the judgment to know there's something wrong with them.
More often, it comes from concerned loved ones, family members and friends who have noticed that this person is not doing things in the manner that they used to, or making mistakes. A lot of times I'll hear about finance mistakes or banking mistakes.
You know, what do you do when somebody comes to you at the office with a concern about their memory? So do what we call a comprehensive geriatric assessment. You look at their ADLs, or their activities of daily living. You look at their IDLs, their instrumental activities of daily living. So ADLs are things like bathing, dressing, feeding, toileting, transferring, incontinence. Instrumental activities of daily living are things like medications, making your food, obtaining transportation, not necessarily driving, cleaning the house, doing the finances, things like that. So we tend to see a decline in the IDLs when people have memory problems. They may minimize them, but that's where it'll often start. And then we look at, are they depressed? We look at cognitive screening. We look at if they're having any falls, any sensory impairment like hearing or vision. My preferred assessment is the Montreal Cognitive Assessment because, one, it picks up mild cognitive impairment much more than, say, the Mini Mental State Exam or the St. Louis University Mental Status Exam. It's a screening test. A screening test just means someone has no symptoms but there's concerns. We do it. If it's abnormal, it prompts further workup. So early diagnoses allow patients to have an active role in their care where they can designate what they would want done if they can't make medical decisions like CPR, intubation, hospitalization. And this is an opportunity to have that conversation because at some point in the disease, they're not going to be able to speak for themselves. So it's important to establish early on who they would want to do that. Once you get a diagnosis and do the medical workup, getting an interdisciplinary team involved, physical therapy, occupational therapy if they have any mobility issues. Speech therapy is very helpful because they work with cognition. They have a lot of different resources. The earlier you get involved, the more you get support structures in place, the better they're going to do.
I mean, I think for us at the Alzheimer's Association, it's having that strong partnership with the clinician. We don't want to be just the place where you're referring. We want to be there every step of the way.
I don't think that people truly understand what it means to take care of somebody with dementia. It is a huge expenditure of energy and it's huge emotional toll on people.
Acknowledge the guilt. The fact is, you're not a trained professional, and they'll tell us, oh, but so-and-so across the street took care of her husband the whole way through. You're not so-and-so. If you can't do this, that's okay. Most people can't.
Take the respite care. It's not a dirty word. You're not leaving the loved one alone. You need that break for yourself.
There are now treatments out there that can, alter the course of this disease, slow the disease progression. And that's a big change. I mean, for 25 years or more, we didn't have a new therapeutic for Alzheimer's disease. I don't want to oversell, like what there is out there to offer. There's no cure, but there is a potential to alter the course of the disease.
I think that One of the cases that really stands out to me was a patient who was brought to me by her daughter. After getting the diagnosis, the family really rallied around the patient, and they were able to keep her in the home for a very long time, even after she became nonverbal, even after she had limited ability to walk. And the family did a phenomenal job in really meeting her needs on a day-to-day basis. And when the time came for the family to kind of make the hardest decision, I was able to sit with them and talk about the options of hospice care and transition the patient into a really phenomenal home hospice program. And in the end, I know that that patient was really cared for well and remained in her home, which was her goal.
When someone hits what's called FAST 7B or 7C or 7D, where they're not speaking, they're not eating, they can't pick their head up, that is usually an indication for hospice. Hospice will help with care. It emphasizes having the best with the time that you have left, functional, hopefully, pain-free, symptom-free, and it also helps with the families.
I keep coming back to just that routine cognitive care can make such a big difference.
We have treatments, and there's so much coming down the line. Like, there's hope. Before there wasn't hope.
Yes.
Yeah.
Now there's hope.